Hi, everyone. Welcome to this session on innovation and access for resilient response against AMR. We have a really exciting panel ahead of us, and we're really looking forward to this dialogue that we're going to have. So just to set this up and give us a little bit of frame for the discussion. This is a global health conference, and we know as a global health community that health is a fundamental human right. And every member state of the World Health Organization has ratified a treaty that enshrines this right in a legally binding commitment. What is more fundamental to the right to health than the ability to prevent, detect, and treat infections? So penicillin was discovered almost 100 years ago. We have since then seen tremendous improvement in our ability to treat infections through further innovation. Today, we have multiple types and classes of antibiotics that protect against an array of bacterial infections. Antibiotics provide an immeasurable value to our ability to live up to our aspirations in global health. We deliver so many interventions on the basis of being able to safeguard people's health from infection, such as cancer treatments, surgery, childbirth, transplants, dental care. We have extended lifespans because of this ability as well. And we know that healthy people beget healthy economies. All of this is now at risk. Bacteria evolve, and in doing so, they have learned to evade our treatments. We are at great risk of these critical tools no longer being effective if our innovation cannot keep pace with evolution. At the same time, despite strides made in increasing the health and well-being for all, we still face a vast inequity in access to treatments, diagnostics, and other tools. AMR is not a future distant threat. It is with us today. Already, over 1 million people a year lose their lives because of a resistant infection. Last month, the world came together at the UN to adopt a political declaration that reaffirms our commitments to a robust and resilient response to antimicrobial resistance. We have reams of data that indicate that meaningful action to ensure sustainable innovation and access would provide incredible return on investment, while the cost of inaction is no less than a betrayal of our commitments. As we move forward in translating the declaration into action, it is clear that all stakeholders have a role to play in following through. So today in this panel, I'm pleased to showcase a diverse set of these stakeholders. We will have government, industry, funders, clinicians, patient advocates. And so we'll begin the session with a fireside chat between Noor Shammas and Dr. Stefan Hagel. While we must address this problem at all levels of society, it's important to remind ourselves what is at stake. And at the heart of a resilient response to AMR are the patients and healthcare professionals who deliver against our aspirations. So over to you, Noor and Stefan.
Hello. All right. Thank you so much. Good afternoon, everyone. Thank you for having us. My name is Noor. I'm an infectious disease and antimicrobial stewardship clinical pharmacist. I'm also an AMR advocate and on the task force of AMR survivors. My mother had an infection, and I'll tell you a bit more about that in a bit. I, at one point, found that taking care of patients that have resistant infections over and over again was just repeating the same actions, the same interventions on a day-to-day basis. So I decided to study global health policy because it doesn't make sense to just keep doing the same thing. And so I'm really happy to be here with Stefan, who will also introduce himself.
Yes, thanks a lot for the possibility to share our experience with this big problem in daily care. I'm Stefan Hagel. I'm an infectious disease physician working in a big university hospital here in Germany. And I think we can start with our chat. And we both deal with patients having AMR infections on a professional basis. But the difference is that you just mentioned it, you had the personal experience with your mother. Can you tell us some points, what kind of infection, what pathogen, and which problems did you face with the therapy and diagnostics?
Sure. So what I didn't mention yet is that I'm from Lebanon, from Beirut. And in 2018, my mom had back surgery because, funny enough, she was exercising and she had an accident. And so around 2 months after that, she started complaining of back pain. So, of course, her physicians assumed that it was a back problem, and at one point they identified that this was actually a urinary tract infection that had gone to her kidney, so she had pyelonephritis, she had also bacteremia, so the bacteria went to the blood, and she had sepsis. I was abroad, funny enough, at a conference talking about infectious diseases, so she had started antibiotics with the team in Beirut, which we are very fortunate because we pay out of pocket for private insurance that makes sure that my mom has access to relatively very quick care, and she was able to get the culture done and get the results within 2 days. And they identified that it was an extended spectrum beta-lactamase E. coli, which to me at the time, that is not such a big deal because I was taking care of patients with pan resistance, with completely resistant Acinetobacter, completely resistant Klebsiella at my setting where I was working at the time. So I was, just talking to her, telling her not to worry too much, you're just gonna take a carbapenem, no big deal, And then she started asking me all of these questions that were really impressive to me and asking me, why don't you have good oral antibiotics for me, a woman who has a UTI, that half the world has UTIs, so why don't you have better antibiotics for women? And why, at the time, of course, Lebanon was going through an economic crisis, so it was difficult to get the antibiotics. And thankfully, we had access to them, but then later on, she started getting recurrent UTI. And this morning, there was a really lovely session about women's health and how there needs to be more research on women's health, and that's what I felt at the time, because we didn't have really good resources, and I had to fly the antibiotics with me from abroad in my backpack because you can't check it just in case they get lost because you're paranoid. So I was really lucky. My story is she's a survivor. A lot of my colleagues on the task force are survivors. But I think what I'm here to share is that we should speak, and all of you should speak for all the people who don't survive and actually don't have the ability to come and share their stories. This is an overview of what we've experienced so far.
And how long did it take the time frame from the diagnosis to the start of the optimal therapy? Was there like a delay, or was it?
I think the delay in our case was the delay in identifying that it's a UTI, because you can imagine that older women in the community are perceived to be complainers, unfortunately, in many societies and in our society. So it was kind of like, don't worry, it's just your back problem. It was very dismissive. So I think it wasn't a problem till, the problem was connecting her to care rather than when she received and was exposed to the right people, she was able to get the right care. The other problem was delay to discharge, because in her situation, it was very easy. We were lucky because this specific organism, you can get antibiotics through intravenously in the outpatient setting, but you have to pay for it. So we had to pay for home health care, which also I have the luxury to afford with my brother, but then we have to pay for it, we have to organize for the nurse to come. And so those were the delays that we're very privileged to have dealt with. But on the task force, a lot of people complained of having months and months and multiple surgeries before anybody thought to test them and before someone thought to check susceptibilities to recognize that it's a resistant infection. Yeah.
And what would have happened without a daughter working in the system?
Yeah, actually, that's something I ask myself every day. What happens to everybody else who doesn't have an infectious disease physician or pharmacist daughter or someone who knows the system? I don't know, and that's probably stories that we will never hear because people don't know about it, and most people don't even know that they had a resistant infection. And one thing that I'll mention is that those luxurious 2-3 days of delay happen 2-3 times a year. So every time she has a UTI, she needs to get tested, right? And every time there's a 2-3 day delay. And every time she's depressed because she's trying to think, what did I do to deserve having this pain, to have to take an IV antibiotic? And for someone who doesn't understand it doesn't matter to the patient if they have a pan-resistant Acinetobacter or an ESBL E. coli. To them, they have a difficult to treat infection, which they need special care. There's stigma surrounding it. You can't hug them for a couple of days because of contact isolation. So I think those 2-3 days, we shouldn't be so okay with the concept of empiric therapy. So for the non-medical people here, it's the accepting 2-3 days of therapy of probably works, we're not sure if it works, it might work, and then on day 3 you'll find out actually it doesn't work. But you're only 10% of those patients, so it's not a big deal. So this is, I think, something we have to change.
Yeah. And what did your mother now thinks about the whole problem of, does she fears that the pathogen gets more resistant?
Yeah.
And you even have more problems to getting the...
Very, very good point. She's actually paralyzed by the fear that because she's reading about it and she's able to analyze it, she knows that at some point her ESBL is going to not respond anymore to the current available therapies. And we try not to, emphasize that, and we always talk about the potential for other antibiotics, but she's very afraid, and she, in addition to everything happening in Lebanon, of course, so now my family had to move out of Lebanon 3 days ago because of what's happening. And so, she carried our baby photos in one part of the bag and her antibiotics in the other part of the bag. So you can think about this is what's important to her. And the fear of, all right, am I going to access, she doesn't have health insurance abroad, so is she going to have access to the care that she needs when she travels? Yeah.
Okay. And if she would get an infection with an even more carbapenem-resistant pathogen, what do you think in Lebanon? Is there any possibility to get those antibiotics, or is there no access, or only access with if you have a lot of money?
Maybe a year ago, I would have said there would be access if you have money for it. But right now, I think the situation is really, really bad, to the extent that I think carbapenems are out of stock very often. So carbapenems, to me, are like the medium antibiotics, because there are much more broad spectrum antibiotics that should be available. So I think that availability is a very big deal, and also diagnostics are running out. The land borders are not available anymore. They're destroyed. Not to get into a lot of details, but no, I think accessibility now is a really big issue. Yeah.
And this is maybe for not the physicians in the audience, this is like ESBL is like a more common antimicrobial resistance. In Germany, we have like a rate of 10%, so it's a quite common problem we face. And as an ID physician, we still have opportunities and possibilities to treat these infections with the carbapenem. So it's not the biggest threat we see in daily care. Like from my point of view, and I think you see the same, like the bigger problem is the pathogens, the gram-negative pathogens who are carbapenem resistant. And this is like a major problem, and we just saw the numbers, the published numbers. And also in Germany, we are in a lucky situation that the overall numbers are quite low with the carbapenem-resistant pathogens compared to other parts of the world, or if you go to southern part of Europe. But still, we have problems to treat these infections because of sometimes they're pan-resistant, and we do not have any possibility or antibiotics to care for the patients.
So actually, that's a really good time to ask you a few questions. And I think that my experience focuses on the patient's perspective. And then I also have been somewhat in your shoes, but not exactly. Could you tell us a little bit more about what you've seen so far as an infectious disease physician dealing with some of the infections you've seen in your hospital?
Yes, sure. So I started ID as an ID physician like 15 years ago, and when I started, it was like antibiotic resistant. It was mainly MRSA, so the methicillin, oxacillin resistant Staph aureus, and this was the major problem. But in the meantime, MRSA is like we have a lot of new and old substances for the therapy of MRSA, so this is not or no longer a big deal. So as I told, now are the gram-negative pathogens the big problem, Klebsiella, Acinetobacter, E. coli, Pseudomonas. And if they are carbapenem resistant, you only have like these like 5 or 3 new substances. And during the last 10 years, we see a constant increase of the numbers. The numbers are still small compared to other parts of the world, but like it changed approximately 2 years ago because of the war between Russia and Ukraine. We now have many patients from the Ukraine, soldiers with extensive blast injuries, and many of them, or nearly all of them, have colonization or infection with these carbapenem-resistant pathogens. And now we see like the problem, it changed really from yesterday to today, like within 24 hours the whole epidemiology can change, even in a low incidence country like Germany. And we have access to all of the new substances, so we do not have these problems like in most other parts of the world. So we're in a lucky situation, but still we face these problems with long care, IV infusion.
And do you think that these experiences are kind of impressing on the important changes that your health system need to put into place to cater to these infections? Because I feel like, yes, you're being exposed to resistant infections now. In the future, you're definitely going to be exposed to more internally as well. So how do you think the health system could adjust to these changes within your setting?
I think as a health system, you always have to think of what's coming next. So it's not, you can not sit back and say, oh, our numbers are low and we do not have any problems and we will just wait. I think this is not the right way to go, because we see it in other parts of the world, and we just heard there's a constant evolution. And even if you have new antibiotics, and you have like 95% the susceptibility, but we already have some pathogens who are all already resistant to the new antibiotics, and they are like going to spread. So you cannot lean back and think, no, it's not a problem in our country, we can wait. You always have to think it's what will be in 5 years, in 10 years, or in the 15 years. I think this is we have to think of.
Yeah. Do you find that perhaps, finding first, I wanted to commend also the system to take in the soldiers, because that's, I think, going to make a big change on their lives and having access to this type of care. But do you think that, in addition to making available the diagnostics and the new antibiotics, what other things do you think that you would like to see changed in your healthcare system so that they can cater to that?
I think we really have to think of antibiotics as precious good, because it's like antibiotics, we just give antibiotics just in case of there's an infection. I think, and this is the problem we also face in all parts of the world, this very high consumption. And if you have this high consumption, you have the selection of these resistant pathogens. So we first have to start with the small spectrum antibiotics to reduce them, and also the broad spectrum antibiotics. And we have constant looking for new opportunities, new antibiotics to be prepared for future.
Yeah, and I think from my side, having these stories and sharing the stories of these soldiers is going to be really important. And they can also share their own stories. As a patient advocate, I think at this point, there's a lot of evidence of what we need to do, and it's time to start bringing it to the front lines and also creating a bit more of action, grounds up action, so bottom up action. So I also urge all the people in the audience to try to find ways to empower people in your surrounding civil society so that they can spread the word at that intersection. Thank you.
Great. Thank you, Noor. Thank you, Stefan. I think that was a really powerful moment. So, As we switch over to the panel discussion that's going to happen next, I just wanted to reflect on that a little bit. I found that really powerful in part because we don't actually hear the stories of people who have experienced infections. We don't often hear the stories of clinicians when we have meetings like this, or when we talk in a in a setting in which we're covering large-scale global action. And so I think it is really important to focus in on the people and the individual stories. We're all a collective of individuals, right? So I think that's really important. And the other thing that I was thinking about is you touched a little bit on conflict, in this, and other things that are uncertain and unpredictable and will disrupt health systems. And so we want to talk about a resilient response. A key driver of resilience is just being equipped with the right tools to be able to address what may come at you that you can't prepare for. And so I think that's a really critical part of this, making sure that the people on the front line are equipped with those tools so that they can respond. And now I'd like to invite our panelists to come up to the stage. And I think you can take the stairs here in the middle. And we're going to actually have a conversation now exactly about how we can make sure that people are equipped with the right tools. And on our panel, we have the Honorable Kumbizi Kandado Chiponda, who is the Minister of Health from Malawi. Welcome. Tamash Kont, who is the Chief Medical Officer for the Pfizer Accord for a Healthier World. Florence Sejourné, who is CEO of Orabac Therapeutics and a member of the Beam Alliance. Kevin Outerson, who is the Executive Director of Carbex. Joël Denis, the Director General for Vaccines and Therapeutic Readiness at the Public Health Agency of Canada, and Wolfgang Philipp, who is Chief Scientific Officer of the Directorate General on Health Emergency Preparedness and Response at the European Commission. So thank you, all of you, and looking forward to this discussion. So Your Excellency, if I can start with you. So we've just heard a bit about the challenges that people face in treating patients and making sure that we can get the right drug to the right patient at the right time. In Malawi, you are working on approaches to strengthen health systems, and I think this has been really quite exemplary, and to overcome barriers to access. And so if you could share with us a little bit about approaches that you've taken to overcome some of these barriers to access, and really to make sure that we can achieve the core mission, getting the right products to the right people. Over to you.
Thank you so much for the opportunity to be part of this very important discussion. Malawi as a country, we endorsed the declaration at UNGA on antimicrobial resistance. Also to say that Malawi, we have now, we're using the One Health approach as guided by World Health Organization. So that is what we are coming from. Now, in terms of AMR, antimicrobial resistance, for us, there's more to it. It's not just about resistance to antibiotics. More for us, we look at that in a comprehensive or integrated manner. We bring issues of hospital-acquired infections. We bring in issues of WASH as well, because those are really, really important issues. And also, we should not forget the role of our clients or our patients or the citizens themselves. Because sometimes, what happens in our communities when somebody, especially the elderly, I was so happy to hear her story. What happens in the elderly, when they see you taking a drug, they say, can I also have, I have a headache. They will not even ask what kind of medicine you are taking, what is it for. And this is very common. These are realities on the ground, and this is what is contributing to the resistance on the ground, which we are seeing. So we are happy that at least now globally, all of us, we are getting concerned, and we are saying, we have to do something about it. So for us as Malawi, we have adopted the comprehensive approach to tackling AMR, and we focus on improving access to effective antibiotics, which I feel is very, very important. Of course, sometimes it is difficult for you if maybe it's a donation or something like that, because when it's a donation, there's very little you can do. Of course, you have donation guidelines, but sometimes, people, they'll just borrow things on you. Also, what we have done is that we're implementing the National Action Plan on AMR, which is aligned to the Global Action Plan to facilitate these efforts. Unfortunately, for countries like us, we face challenges because in terms of manufacturing, we have low capacity of manufacturing drugs ourselves. Almost, I can say, maybe 95% of all antibiotics which we use, we have to get them from outside Malawi. So it means in terms of the quality, we might be assured, but still, you cannot be 100% sure that what you are getting really is of very, very good quality. So it's something which we have to work on. We're also working on strengthening our regulatory bodies on the same, because they're the ones who are responsible for registration, and also to make sure that the plant where it is coming from, it is a good plant which has passed the good practicing manufacturing practices as prescribed by World Health Organization. So in terms of One Health, it means we're also working with the Ministry of Agriculture and of course the Ministry of Finance, because whatever interventions we have to use, it will require resources as well. We are grateful to the Fleming Fund of UK because they've been very, very supportive in terms of providing us resources. So one of the aspects which is also part of the activities we are doing to fight AMR is strengthening our laboratories in most of the district hospitals. So we have already embarked on that one, district hospitals, but also the laboratory for the animals as well. It is also being worked on to strengthen its capacity. And of course, we cannot do all this without extra human resource. So human resource capacity building is also part of the same. So I think let me stop there for now.
That was excellent. Thank you. And incredibly comprehensive. And I think you're right, there is this much broader context in which we think about AMR and the way that we address the challenges. And it's very much contextualized to the local needs and the local situation. But having that very comprehensive view, I think, is really critical. Tomasz, it'd be great to get your perspectives on this as well. I mean, you have an experience across multiple, economies of lower and middle income countries. And so what kind of approaches do you find successful for addressing barriers to access and dealing with AMR?
Thank you so much for the invitation, and it's very great to hear primarily from Honorary Minister from Malawi, because I would like to use some of the examples actually about the collaboration that we can deploy multi-sectorially. But allow me a personal comment first time. I think it's because you brought this up. You talked about penicillin, and I'm here also representing my employer Pfizer. And of course, you know that we have a history, and we're very proud of that. And I would like to tell you later on how we continue to make sure that there is access for patients also in the antimicrobial space. Another personal comment, I think I can say this in Germany because many of you will be familiar with that. I actually studied medicine at the Ignaz Semmelweis University, and you will probably all remember that almost 200 years ago, when we didn't know much about bacteria, this was a doctor who actually forced the medical students to wash their hands after they did the dissection of the deceased before actually looking at the going to the maternity ward. So he saved many, many lives, and I think we are all here to continue in this tradition. And I think going back to an example of almost 200 years ago, or the Second World War about penicillin production, I think look where we have come to. So let me be a bit more specific about the access and the question. Access is improving, and Deepa, you asked me about low and middle income countries. It is improving. Actually, according to a study between 2000 and 2015, there was a 114% increase in the antimicrobial consumption in these countries. Now, you might argue that this is a good thing. It is a good thing, definitely, but also if, as we said in the beginning, if patients are not and physicians are not using it appropriately, then it's going to lead to problems. So this is where we are, right? So we need to fix the challenge of access, And I will come to that with some of the examples I have. But I think what is even more important is the overall approach by all of us collaborating. So the burden, just a couple of examples, the burden in the lower and middle income countries, Malawi, for example. I believe one study says that 19,000 deaths a year are attributable to AMR. In the whole of sub-Saharan Africa, attributable is more than 200,000 deaths and maybe associated almost up to 1 million. So we're looking at a very serious problem, and of course we know from the recent communication from the African CDC and others, is that it's becoming probably one of the biggest, if not the biggest, healthcare burden, superseding now HIV, AIDS, maybe even malaria and tuberculosis. So we all know that we're looking at a very significant problem, and the way we look at this, we launched the program that is called Accord for a Healthier World. And this program at Pfizer makes our entire portfolio, including many of the anti-infectives, available at cost. This is probably the most important word here, at cost, to the low and middle income countries. It's 45 countries that are eligible, and we're working heavily with Malawi, and I will give some examples. But it's not just about the medicines, right? So this is why I wanted to mention to you the challenge with the access. It's much more than that. It's how these medicines are being used, how these medicines, how the diseases are being diagnosed, going into the antimicrobial space, right? How do we deal with diagnosis, with prevention, with infection control? How do we build up the laboratory capabilities? How do we deal with the medical education? How do we collaborate with the pharmacies and so on? So we will come to that. Let me stop here. But thank you so much, and I'm really, really pleased to be able to tell you a little bit about how we can collaborate all together on behalf of Pfizer.
Great, thank you, Tomasz. So it is absolutely critical that we reduce barriers to access and ensure that that access is equitable. And I think we have some really great examples of this. It's also important that we have products to access. And so as we are seeing challenges with filling the pipeline with suitable candidates that we can then in the future be able to access, we are probably feeling a sense of urgency to make sure that we have this really sustainable ecosystem. So turning over to you, Kevin, can you tell us a little bit more about what's happening with the pipeline? How strong is it? What solutions might we need there? And do we feel a sense of urgency about this?
So Kevin Outerson, I lead CARB-X. I was at the G7 Joint Health and Finance Ministers meeting on Thursday of last week and presented their latest data about the pipeline. And to cut to the short, if we focus on just the highly innovative antibiotics, the ones that target the worst things on the bacterial pathogen list from the WHO, and that also have some characteristic of innovation as determined by the WHO priority, the bacterial pathogen list, then our pipeline right now is pretty thin. There's 20 projects globally in clinical development that fit those two criteria, 20. For cancer, well over several thousand. You know, it depends exactly where you look, but you know, many multiples higher for oncology. The current pipeline, however, 20 is not what we're going to have. If we don't act now, the best data that's available that we put together for simulation for the Italian G7 is that that pipeline within 4 years will have to less than 10 programs in clinical development globally, and in 4 more years after that, have again to less than 5. We've all seen the slides from on the Leaving the Lab report, all of the people who were PhD or MD researchers at antibiotic companies, large companies that then the program got shut down, and where did they go? You know, a small number of them went on to antibiotics, others went off to other things, and then it tracked them on LinkedIn to see where were they 5 years later after maybe a second job change, and I think 18, you know, less than 10% were still in antibiotics 5 years later. Right now, we have a crisis of human capital. Do we have enough people left in the world to do this work? And if we don't act with sufficient push and pull incentives, the pipeline essentially collapses within 4 to 8 years. So I'm not usually known as an optimist on these sorts of stats. The good news is that the G7, 4 years in a row, has said they really mean to do something helpful in this. And that with Italy's announcement on Thursday, we actually have a second G7 government who has a pool incentive which is fully funded and meets the fair share criteria. So there's motion, but time is running short.
So I like this was a very pragmatic mix of, things are a bit dire, some movement is happening, so I think, we can take a more positive outlook probably as we think about that. But most of the innovation that's happening in antibiotics is sitting with small companies. They have thin margins. They're operating on, very tight environments around financing. So Florence, you run one of these types of companies, focused on AMR R&D, and you're also representing the Beam Alliance, which is an alliance of many biotech companies in this space. You've also been in the space for a while yourself, so you've seen a lot of what has changed, for the better, for the worse, over the last few years. So can you just reflect a little bit on that and also on some of what Kevin has said? And do you agree? Do you disagree? Do you have a different perspective?
Sure, thank you. So yes, I've actually funded the Beam Alliance, which is the European group of companies here in Europe, back in 2015, so nearly 10 years now. And well, there have been really good things, and you pointed a few of them. Awareness, for sure. Awareness of the public health issue everywhere, WHO, G7, G20. Awareness that AMR innovation is in a broken business model right now, needing incentives, otherwise we won't make it, and Kevin said it. And I think, thank you to the UK, who made it for real, a subscription model in the UK. Very something to highlight as a good example for others to follow. We know Europe is currently considering a few solutions in the pharmaceutical legislation at the moment. We're waiting for the US, and we'll talk about colleagues in Canada in a few minutes. So clearly the pool incentive importance has been there, and up to those incentives to be available, the broken business model will remain, for sure. And there's been very nice initiatives on the push side, the grant side, and Carbex is of course one, with I think 100 programs now funded. There has been as well the AMR Action Fund set up in 22, was that right? and Guard P for allowing for innovation and access at the same time. So a lot of initiatives and things. However, as we speak, the business model is still broken. So small companies struggle really hard to get funding. They go to Carbex up to phase 1. There are fundings at BARDA still to highlight as well, and AMR Action Fund for phase 2, phase 3, but 20 compounds in clinical, that's dramatic, right? To be honest, considering, you remember we have 20 chance of success from phase 1 to market, so will we have 2 compounds in the market from this? This is terrible. We know the last 10 biotech companies who actually brought product to market, regulatory-wise, all died or have been purchased at a very, very low price, so lost a lot of money. So this is what we mean by the business model is broken. Private investors are not even replying to emails for us trying to fundraise. So there is absolutely no interest from private investors in the antibacterial fields, which is complex. 60% of the BEAM members have less than a year of cash to fund employees. And 54% of the BEAM Alliance members are less than 9 employees, to give you an idea of who actually develops those antibiotics right now. So the maturity of the pipeline is decreasing. Very little clinical assets. Still good initiatives from academia today and quite nice ideas we would like to invest in. And, but definitely, I'm going to conclude with the same sentence as Kevin. People are going away. And I've just had the chance myself to fund a new company, Orobac Therapeutics, 2 years ago. And finding people with experience is extremely complex today. Many of the people who invented the drugs, like chemists, left to other fields oncology and stuff. So we're trying to get them back in scientific boards, but they need to have a pay at the end of the month, and they go out, and this is real expertise loss for us.
Yeah.
So you're absolutely right. The world is relying on micro companies. Companies with less than 10 employees are the greatest share of what Carbex funds and the greatest share of the Beam Alliance membership. That's a very fragile base for the world's most effective, most important drug class to be in the hands. These are great companies, but they need help and they need more people. Second thing is that since the meeting at G7 was the health and finance ministers, I made the economic case for a small, reasonable investment and push, and most importantly, pull incentives together yields amazing return on investment, both on the health side as well as the economic side. Because it's a rare opportunity to be able to speak not just to the health people, but also the finance people. And so we have a problem, and we know that it's desperate, and companies are filled with innovation, but not enough capital to move things forward. But we really are on the cusp of a solution as well.
Yeah, absolutely. I think, Tomasz, did you want to weigh in?
With respect to the other panelists as well, just 2 sentences here. So I completely agree with your description, and I also come from the world of R&D. Just on a more optimistic, positive note, obviously we need the ultimate innovation. At the same time, there is a lot of low-hanging fruits, which for me form part of the R&D, because we're talking about the safe and effective use of appropriate patients of these medicines. And if we talk about the older versions, the older antibiotics, and especially about the countries where we are working now for access, even the most basic medicines that we all know very well from the developed world, we need to make sure that we are collaborating, and that forms part of the R&D, right? So it's all about the longer-term outcomes. What happens of using these medicines over the long term in these countries where we do not even have data, and that will actually hopefully feed into the R&D programs as well that you're looking at.
Yeah, absolutely, and I think it is a holistic view of the market that drives innovation and access that we really need to be thinking about, and who supplies into the market, who receives the products in the market, and all of the challenges that all of these stakeholders face. It's quite complex, but everyone has a role to play, and I think it's really important that we kind of address these things. Maybe, Wolfgang, over to you. So our European biotechs are struggling, but in the recent years, the EU has prioritized AMR as part of the pharmaceutical strategy, for example. How do you see the Commission take this forward concretely in terms of these commitments and the understanding of what the challenges are? And what do you think is needed to avert this, if it's possible to avert this crisis in innovation and access?
It's a very, I think the most often used word is complex in all of these discussions. Starting with Kevin, with Florence, I mean, that's all the time. We are sitting very often on panels and we have the same kind of discussions. We dissect the problem, we see what the problematic factors are. At the end of the day, it goes back to money. It goes back to investments and goes back to speed. I mean, we have heard this from Noor. I found this very nice that you opened that discussion here, because it's a kind of a grounding back to what the whole thing is about. It's not about the report that comes out once a year and saying, in the EU we have 30,000 people dying of antibiotic resistance, or somewhere else it's even more, or we have so and so many cases from these or that infections. I think it's about something very personal and something that is happening all the time, everywhere, to everybody. So therefore, that was the kind of introduction from my side. No? So let me come back to your question. I don't have an answer. I mean, I work for the European Commission, the Health Emergency Preparedness and Response Authority. That sounds very technical. What we are doing is we invest, or we were created a couple of years ago to invest into the development of medical countermeasures. Antibiotics, antifungals, all kind of antimicrobials are medical countermeasures as well. Perhaps not for an emergency case, but I think the AMR field is a full case of emergency. So therefore, we have been putting AMR as one of the 3 priorities when we started 3 years ago. as a field where we would invest. We have been doing this so far with different approaches. So so far we have been investing already over 100 million euros. That's a lot of money. Where's the product? I don't know. But there is investments that go into organizations like GARD-P. It is investments or support to work that is done by WHO. We also invest into the development of antibiotics, later stage development so far. And we are also starting next year a pilot project about pull incentives. So to combine that push and pull, because there is needs on both sides, that's very clear, where we try to increase the access to this time only one antibiotic, but across the EU. That might make a huge difference for many countries. And the model is very much what other countries are using as well, like Canada or others. So what I wanted to say is we invest a lot, we have a lot of discussion, we get a lot of feedback, but at the end of the day, I think what is needed or what would be really a matter of success is to expand pipelines, and that requires R&D funding. I mean, very simple. We would not have that budget because we are funded in a very strange way, but there is certainly other parts of the Commission funding these things through partnerships and all kind of models. So that is happening, but it's difficult to invest directly into companies like Florence's. I mean, we are having the financing instrument that provides loans. That's not the best solution for many companies. You're looking for capital. That's very clear. But at least we are working on all fronts and really expanding the instruments that we have to invest into push and pull and financing of companies as well. So that's what we are doing. More specifically, perhaps I can come on a couple of more specific projects later on.
So I will ask you a couple of more specific questions on that. I'll hold that for a second, though, and come to Joël now. So we have heard on the ground experiences from patients, from clinicians. We've heard about health systems and the broader, approaches that are needed. We've heard from innovators and funders. Maybe zooming out a bit, I think when we think about what's needed at global level, it's really about what we're doing that serves the people that are on the ground and dealing with this, on a day-to-day basis. We've just had a high-level meeting. AMR was featured at the G7 Health Ministers meeting. There will be a high-level ministerial in AMR next month. And Canada will hold the G7 presidency next year. So eyes are starting to turn that way as well. How does Canada intend to elevate the need for AMR R&D and access in the G7 agenda next year and going forward?
So thanks for the question, and thanks for the invite to be part of the panel. I just want to really appreciate the initial speakers that set the stage. We need more, I think, conversations around patient and on-the-ground experience from the perspective of governments and trying to explain this to decision makers and get investments and buy-in. Your language is much better than anything we can put in a briefing note. So thank you very much for being on the stage. For Canada, we're coming off the heels of what we feel is a fairly important year for us. We published our Pan-Canadian Action Plan, signed off by Ministers of Health and Agriculture Ministers, with commitments including incentives. We're coming off our initial modest but still important to us round of investment with Carbex. And we have our commitment in our federal budget for a launch of an economic incentive to increase access to address Canadian need. We launched an arm's length panel, a council of Canadian academies. This is prominent researchers in Canada, made up of all kinds of different expertise, of course, infectious disease, but also from an economics point of view, law point of view. And they reached out to many different domestic and international experts in this space, some of which are on this panel and some of which are in this room. And I just want to thank all of you for contributing. That report, which is public, was set to inform our design. It was really our launch of getting information around what was going on internationally and overlaying it with the Canadian context to see what could be similar and what could be different. And so what are we doing now? We're doing the hard work of actually making the pilot move from commitment to be a reality. Just a side note, in a previous life, I was a member of our national taekwondo team. And my instructor used to always say, when he'd ask, well, how do you think the training went or a competition went? And you would respond, and he would always say there's a difference between feel and real. How you felt it went, but how he thought it went, or how it actually went can be two very different things. I felt we had done the big lift in getting ministerial and decision makers to agree to the pilot and to fund it. I got to tell you, it was nothing compared to the work of working through the implementation mechanisms of actually making each of the elements that are part of a pilot functional, and maybe in our federated system. So just to give you a few examples of what we're doing. So from a design point of view, we'll be pursuing an annual guarantee approach. From the next step is we spent time, again, with an external advisory group, a different one, defining what we described as unmet need. What was the public health impact we were actually trying to solve, and boil that down to a priority list. Equally not easy. Different infectious disease specialists, with different views around what's needed in different regions in the country, different population groups, but there's only so much money and there's only so much time, so we have to move forward with something. So trying to even get agreement of that takes time. In addition, the incentive itself, so we will be delinking the federal government incentive amount that we're paying for the annual revenue, which will be regardless of the volumes of sales that are produced, in addition, obviously, to the sale price, which we've been working on. And so even that, what is the quantum? Yes, we have got models. Yes, we've seen the plethora of slides, Kevin, on the fair share and the spectrum of money. But when you actually have an envelope that's been decided by decision makers that you have to work your way through, you need more than a few bullets on a slide. And so actually unpacking that as to what you're getting for value for money when your stewardship for public funds matters. And I think a couple other areas are on the regulatory process. Again, knowing that there were some challenges, the report highlighted many of them. Not an easy space to get flexibilities. If you get flexibilities for one area of product, what does it mean for a country to do flexibilities on others? And so thinking through how can we actually maneuver in the regulatory space, which has been one area of criticism by some of the companies, has been something we've been focused on, and we'll be piloting a few examples there. And the last, what's really important to us is on equity. 20% of Canadians live in rural or remote or indigenous communities. These are often the areas that have the hardest ability for access. They have a very different story of access of when a high-income country talks about access for the new yet-to-be-developed product. They're talking about products that do exist today that they cannot have access, and this is in Canada. In some of these areas. And so a big portion of our design is around the elements that relate to that, and small things like logistics of how the product could actually possibly be stockpiled in some areas to speed up delivery of access into these more rural and remote areas. So focusing on that. And so while incentives are important and critical, and of course we believe that, and that's why we're doing what we're doing, implementation is imperative. If we can't actually figure out how, it won't matter that we have the money or the buy-in. In fact, it'll be worse if we don't think it through correctly and do it right, because we will have wasted that capital. And I don't just mean the money, I mean the political buy-in for action. So, thank you.
Yeah, I mean, the stakes are high as you look externally, obviously, but also your internal stakeholders. And so I think that's important that everybody is really cognizant of that. Implementing is always challenging. Multiple stakeholders that are involved. I understand in Canada you also have the sort of differences at federal and regional level. And I think, Wolfgang, you also spoke to some of this as well, that there are challenges that can arise with how systems are set up and structures are set up. And then ultimately, at the end of the day, there is this question about financial commitment and, who decides that? How do you get the buy-in on that? So I think very important, and really appreciate that you've both walked through some of this and the challenges there, and that there are steps that are really being taken. I guess the question that I would then have is, it is really important that we have access in all of the places that we need access. I mean, that nobody would argue against that. But as we said earlier, bacteria evolve. We will need new antibiotics in the future, and they take time to develop. So if we aren't investing now, we are just pushing this out to when we will actually have those. How do you frame that type of conversation in political decision making? And I think I can ask this question to both of you, because I think you're both having to deal with this. The investment you take now or make now won't yield results for 10, 15 years when you're talking about innovation. Political cycles are much shorter than that. So how has that type of a conversation gone? And are there opportunities to really hone in on that piece of it? And maybe, Joël, you can start, but I'd love to also hear from Wolfgang.
I think there's a window of opportunity now of the nexus between, say, academia and industry and governments and decision making in biotechnology. It feels that way. I don't know about what country you're from, but different industries have experienced that kind of maturity in different places. So if we're in Canada, that linkage of bringing those three areas together and investments that's going all in one place, you can see it in some sectors, example, auto sector. But energy sector a little bit more has evolved. Biotechnology is very new in bringing all of that together and having it move in the same direction. Post-pandemic and through the pandemic, there was a lot of, relative to Canada anyway, investment in the space not specific to AMR, but in biomanufacturing at large. $2 billion fund and investment, incubator fund. This past year, 500 million in 5 research academic hubs, 2 of which have a heavy focus on AMR. And just recently, Canada announced the creation of a Health Emergency Readiness Canada organization, maybe a little baby HERA, that's moving in a similar direction of a recognition of the innovation space and needing to knit together more of that public health driver of those investments. And so part of that new entity, what we're very proud of is it is a joint health ministry, industry ministry-led organization where the health minister will be setting the public health priorities for industrial policy and investment. This won't happen overnight, and like you say, it'll take time, but we're building these structural mechanisms to ensure that the industrial space is aligned with the public health need.
Absolutely.
I just would like to add, I mean, when it comes to funding research and development for antibiotics, the question is also who should fund that and to what extent. And the second point is who is channeling it and who is taking responsibility, and basically perhaps also the governance to say these are the priorities, apart from everybody has priority lists, no? But I mean, what are you really focusing on, and when can you realistically reach an endpoint? So therefore, it's more kind of it's a competing field nevertheless. Although it's on the top of any kind of public health discussion, but it's a competing field against many other things. So we are trying to put as much as possible along the whole life cycle, as I mentioned it, and. There is many activities going on also with EU member states. This partnership on AMR is going to be a big package at the end of the day of a couple of 100 million, hopefully. So that might bring a push. But at the end of the day, I think it's really time to channel the funds which are available through public side, philanthropics, also industry, into the way that we really fill the pipeline again. And move on also with clinical developments of candidates, also of repurposed products. So there's no time to lose, that's very clear. We are trying to do our best, as I mentioned. I mean, at HERA we have been putting 100 million into this. We are also putting a lot of money into vaccine development. We're putting a lot of money into diagnostic development. It's all about 1 billion roughly per year but which is earmarked. That sounds a lot, but at the end of the day, you need to have a product. You need to have something that brings you close to the market, and that comes with a lot of failures. And that is what we also have to accept in the public side.
Yeah, absolutely. So Kevin, having heard all of this, I'm curious your thoughts now. Do we have momentum? Are we going to be able to course correct in time so that we don't see this sort of continuing halving of the pipeline as we go forward? Or if not, what else do we need to do?
Well, we've made a lot of progress since 2016. We didn't have, the GARD-P or CARB-X or the AMR Action Fund. We've rolled out national action plans in many countries, and I know that there's vast needs to fund them correctly and to have enough money for them. And now we have a global target on mortality, which I think we'll see how we do, and we'll course correct. Also have an independent science panel coming. There's lots of things to be excited about. Can I say something about Joel's comment? I'm going to, even hopefully you're okay with it. $2 billion investment in Canadian biotech and $500 million in Canadian research universities. Governments are used to spending money on important things when people make cases, even if they're really long term. I'm thinking, how much money does all of our governments spend on bridges or tunnels or rail systems or fire protection systems every year? We spend money on infrastructure when we understand it's important for the way that we live. And the case that we're making increasingly now is that antibiotics are the underpinning of everything we do in medicine. It's actually infrastructure for civilization, or to be as grandiose as possible about it. And we can get ourselves out of this pickle with actually an incredibly reasonable amount of money that will have a great return on investment, both for health as well as for money. And there's really close to consensus in the community on most of the action steps. So I'm very hopeful about that.
Yeah, and I mean, to just add to that, I think almost every intervention that is suggested for addressing AMR, whether it's innovation, access, or anywhere else, the data show return on investment is positive. Every single intervention for AMR. I don't know how you can argue against that case. So I think hopefully we can turn that into some action. Florence, maybe just coming to you quickly on this, because again, you run a biotech company. You're in the midst of this. You're facing these challenges around financing. You're hearing more challenges around financing that you're hoping to be able to access. So, what keeps you up at night as you're hearing about this? What concerns you here?
A lot.
One thing. Give me one thing.
Oh, just one thing? No.
Top priority.
I think the role of biotech is to bring product as close as possible, ideally, to market. So I think our main worry as a first step is to do our job correctly. So it's mitigate risk of failure. This is what we do. We're risk managers. Coming from my colleague from Roche this morning, saying the route to market is neither direct nor predictable, or this is what we try to do to make things having less risk. So efficacy, safety, something super important, regulatory pathway, and clinical feasibility. We actually have, so our job is to bring them to clinical, and so I think most frequent worry is actually to show efficacy of a drug in clinical studies that are feasible, reasonable size, reasonable cost as well, and this is a very, very big challenge in R&D of antibiotics. Remember, antibiotics are actually difficult to identify. The chemistry, the biology of antibiotics and bacteria are still explored right now. So there are pure scientific challenges and clinical challenges. And of course, we're doing this, we're private companies, we're doing this to create value. And as we have well perceived today, when working on net present value of our compounds, we have issues. We get negative net present value, so that's a permanent worry. And last but not least, cash availability to actually pay our teams. And this is probably, I'm a little lucky myself being in a situation which will not last, but having the support of bigger companies. But most of my SME colleagues, really biotech colleagues, have a clear worry that make nights quite difficult, which is to know when you will not have cash anymore, and with very limited solutions to be able to bring your company forward. And going through a bankruptcy is very difficult, and there has been so many and still ongoing now. So this is probably the most difficult part for small companies, and it's very frustrating compared to the medical need that everyone is telling. So that's very schizophrenic feeling.
Yeah, I mean, I think when we talk about, it's important to hear the stories of people who have experienced AMR. I think it's also important to remember that companies are made up of people who are trying to do the jobs, that will net us positive public health impact, and in a climate in which everything is working against you, it feels like. So I think that's really important. And you mentioned that the road to the market is, winding and a bit arduous. I'd say the road to getting those innovations to patients is equally winding and arduous. And so Tomáš, maybe to come back to the heart of the matter here, which is how do we get our innovations to people? We have so many perspectives here, some great passion as well. And I think this question of access and ensuring that the right product gets to the right person at the right time, for industry, you really need strong partnerships to be able to do this with stakeholders, and that includes governments as well. So how do you plan to build those partnerships as part of the Accord and even beyond? What risks do you kind of see there, and what is a sort of vision for success?
Yeah, absolutely. The vision for success is exactly what everybody else mentioned here, right? We would like to overcome this problem. We would like to make it sustainable. And I'll give you some examples, but I really like, Joel, your metaphor of the taekwondo. Of it's one thing what you think, let's say one thing what you put out as a policy paper, and then actually one thing is what actually happens, what actually happened in the fight, so to speak. So whatever we do, for us the most important thing is to measure the actual impact. And I think it gives back also to this discussion, right? Because I think we're going around the topic of return on investment, running out of money or not having the money, short-term perspective versus the long-term. I think if you look back of history of medical innovations, and let's just pick on vaccines, which are a bit more relevant here, right? If you actually calculate the cost effectiveness of these various interventions, it is really a no-brainer that they were worth it, right? Yes, obviously during drug development, vaccines development, many will fail. That can be incorporated into the assessment, right? So I believe that, and I'm going to move on away from just purely the R&D discussion, but I think what we really have to make sure is that we do the appropriate economic evaluation as well, beyond, of course, the efficacy and the safety and the manufacturing quality and all that, and overcoming the regulatory hurdles, but making sure that we do the health economics of it. And we talk about a global problem. We can take perspectives, right? It may not be positive in the net present value of a particular investor, but if you take the longer perspective, you take a societal perspective, there's a lot of arguments we can have there, right? And then we have seen exactly after COVID, for example, how much discussion there was about whether it was worth it or not in terms of financial sense as well. So that was just a little response to the previous discussion, but I absolutely agree with your challenges, the way you put them, and we would really like to make sure we're part of the solution. So to be a bit more specific how we do this, and coming back to Malawi. So I'll tell you, and Honorable Minister, hopefully you will also not mind if I mention that some of the programs that we do is, for example, with Malawi, in partnership with the University of North Carolina and with one of our diagnostic partners, bioMérieux, we are working with the 4 central hospitals, and let's make sure I'm not missing their names. It's Kamuzu, Mzuzu, Zomba, and Queen Elizabeth, right? So there are 4 main hospitals where we are making sure that there is a multi-sectorial team with the ownership of your government and with the complete encouragement and empowerment and collaboration of your government of bringing in these external partners, right? We're talking about industry, in terms of access, we can provide the medicines. We'll provide other things as well. I'll just come to that very briefly. Then, of course, we have the diagnostics, right? You know, we're talking about AMR here, very, very important. And then academia. And again, academia goes back to expertise overall, but also assessing the impact of our interactions. And so for these various hospitals, for example, the 4 key central hospitals, we have a program where we can actually come up with local strategies for antimicrobial stewardship, right? So based on the local tests, based on the local data, we know what would be the specific answer, right? So this is how we drill into kind of the bigger ideas of, you know, let's provide access, let's save the world, but actually how does it look like at the hospital level, at the actual patient level, so that we can go back again, that the patient, the appropriate patient gets the appropriate treatment at the right time, right? So that's what we're hoping to achieve in many other countries. We have something very similar in Rwanda, going on with another diagnostic partner. And we're definitely working with many of the other countries. I was just coming into this meeting, I was reviewing our own materials as well, is that the Democratic Republic of Congo, Senegal, Uganda, all your neighbors as well, they have their very similar AMR programs. And again, we're there to really make sure that we're helping really just executing, and I think that also came up before, right? So execution, and of course, looking at the impact of what we execute on. So a few closing words on this one, because we talk about access, we talked about innovation. I do believe that innovation is not only in top-notch R&D, although I will be the first one to be fascinated, and I would love that as well, and we need that. But I think there's innovation in a lot of other areas. Innovative regulatory pathways, innovative supply chains, innovative education, medical education. One example I would like to mention again in regards to Malawi and some of the other countries, it's with Project ECHO, we do the Teach AMS, right? I'm sure very many of you are familiar with that. So obviously, it is the execution, right? When we're working in collaboration with the governments, with the multi-sectoral partners, and the very physicians, the very pharmacists, and ultimately with the patients as appropriate, to make sure that everybody knows what is best, what is evidence-based, how we could advance the particular specific problem in every single patient's case, as we heard from Lebanon. So how do we get there? There's a lot of complex pictures. There's a lot of things to do in the field where. My last words from me on this one. We, with the Accord program, we launched this program 2 years ago. We would like to see as many of you as possible to partner with us. So please come, academia, NGOs, governments, industry. This is something that we will never claim that we can do on our own. As we all know, we have to collaborate. So I would just like you to take away from us that the Accord program is one of the avenues where you can also make your impact together with us. So thank you so much.
So, and finally to you, Honorable Minister, if you can leave us with some closing wisdom on this. You have so much experience where it matters in ensuring that we are getting the right products to the right people. What is it that you would like the rest of us to know, and your colleagues across the African continent, in terms of what is needed to address AMR and make sure that we have this equitable access, especially in light of these commitments that more recently we have made, like the Lusaka Agenda, around ensuring that we have ownership towards meeting these commitments for health for all?
Thank you so much. A lot has already been said, and I do want to agree that we need more research and more research. We need a lot of investment in the same. But for me, I think what is the most important thing is that apart from all this, we need really to sort out the issues which are on the ground. Because for a woman in Malawi, in a hard-to-reach place, there's no nearest hospital, even a health center, to access any health services. They'll be forced to buy antibiotics in the markets, and that is the reality on the ground. So let's go on the ground. What are the real issues here? There's no hospital. There's no even a health center. People are openly selling all different types of antibiotics in our markets, and these are the issues which are there. And these are the issues which are contributing Let's solve the issues which are really on the ground. What is happening to our people to get into this situation? In our facilities, what are the situation? I talked about the issues of wash, hygiene and sanitation in our facilities, most of our facilities, very pathetic, very, very pathetic. You cannot do any infection prevention control because of issues of wash. Fueling, infections in our facilities. We have to look at the hospital-acquired infections as well. What really is fueling this? These are the real issues. So I think as much as we're looking at the innovations to tackle the same, access to tackle the same, but I think the most important thing is to look at what exactly is fueling AMR in our facilities on the ground. That will also be a huge part of the solution. Yep. Thank you so much. And of course, the last one, the political will.
Yes.
The political will, very, very important in any country. You need to have the political will from the highest office. Thank you.
Absolutely. Thank you, Minister, for that. I mean, I think at the end of the day, the crux is maybe that political will. It will unblock so many of the other issues that that we're really talking about here. And I really appreciate everybody, giving us your time and taking your best effort here to, address this really complicated challenge. We're not going to solve AMR in 90 minutes here, but I think there was a really good flavor of these challenges that different entities face. And I think for me, one of the key themes is really that we are trying to pull together, we are trying to work together to address these issues. Maybe before we move to taking a few comments from the floor, in the spirit of telling personal stories, I think I just wanted to add one personal story of my own, which is, and this is kind of reflecting the on-the-ground experience. I have a member of my family who, she's trained as a physician, and she trained in India at a time where polio was paralyzing thousands of children every day. Several decades later, India eliminated polio through a mobilization that I think if you are not from India, you cannot understand the scale of the mobilization that occurred to achieve this outcome. This, prior to that, we eradicated smallpox, very similar, massive mobilization. So I think we can mobilize and address the challenge of AMR. We have done it in so many different areas. There's not a reason that we can't do this now. So this particular family member of mine is now battling cancer. And I start to think about, her personal risk now, for example, around infection and other areas. About 10, 15 years, she's a psychiatrist. You're probably figuring out who this person is. So I'm not going to name it because I haven't asked her if I can share the story. But about 10, 15 years ago, she visited me when I was in Washington, D.C. She went to Congress to advocate for an issue that she really cares about, which was related to child health. And so in her sort of progression of, how she addresses the core challenges that she sees, I think there's really, for me, a really important lesson that, we need this collective action, but this collective action is a collective of individuals taking individual actions that together will hopefully scale up to something really important. And that is the massive mobilization that we saw in India to eradicate smallpox and to eliminate polio. So I think there is some hope for this. I think we have a sense of urgency, and I think we're really, really kind of on a good path. I'll be the optimist in this scenario. Actually, rarely I'm the optimist. So you're getting a special case here. So we're going to turn a little bit to the floor to, I think we have a lot of questions, but I have been asked to give some time first to Peter Bayer and Michael Lobritz. I don't know. I see Peter, I see Michael. I'm not sure where the microphones are. So maybe if we can give the microphone to Michael over there. And you can start, and then Peter as well. So there were two other sessions that happened today on AMR, and they're going to just give us a little bit of a summary of what we heard this morning. So go ahead, Michael.
So Dipali, first, thank you very much for sharing a personal story. What a great day for conversations on antimicrobial resistance. I think I've been in AMR meetings from the beginning of the day to the end of the day, and that's exactly where it should be. I'm summarizing very briefly a session from this morning called Breaking Boundaries, the Promise of Innovation in Antimicrobial Resistance. And thanks again for the opportunity to synthesize and allow this to be built upon. So this morning, I think there was the 5 themes that I'll bring up, which I think were highly resonant today. The first is science. The route from lab to trials to medicine is not direct or predictable. And I think one of the themes around that is that we need new medical innovations. Innovations requires innovators. Innovators have to pay their rent. And that is something that we need to solve for. The second is around AMR and cancer, that infections are now the second highest killers in cancer patients, with 1 in 5 requiring hospitalizations due to infection, and that cancer patients are twice as likely to experience infections that cannot be treated. Third was a conversation on public-private partnerships, which echoed again today in this session. We discussed AMR as the world's most complicated team sport. Collaboration across public and private sectors is vital for tackling AMR, demonstrated by initiatives like CARB-X, like BEAM, and developing new business ecosystems that bring together different expertise is crucial. The fourth topic was accountability. A UN declaration won't mean anything unless it's properly implemented. Governments must adhere to the commitments of the UN declaration and seriously tackle their obligations related to AMR. Governments should prioritize monitoring and data collection to understand AMR's burden and ensure appropriate action. And enforcing regulations and ensuring responsible use and disposal of antimicrobials are critical for combating AMR. And lastly, low and middle income countries. We cannot forget the challenges in low and middle income countries, and are particularly acute. We need to focus on appropriate use and access. Thank you.
Thank you, Michael. Peter, go ahead.
Yeah, thank you for giving me the floor. I had the honor to moderate another session on AMR this morning. I wanted to congratulate first the World Health Summit, a fantastic new session format, these fishbowl sessions, so refreshing. We want more of this next year. We picked up what the esteemed minister said. I mean, these basics, IPC, and all the challenges you mentioned came up in our session, and all the investment needed to do on political will, but also access to the necessary PPEs and hand wash, alcohol solution, and so on. And I think this was important because we know that this is actually going to have a huge impact on the disease burden. And from that we moved, because we know that we can't prevent all the infections, we moved towards the issue of R&D and access. And here present, he showed us what he is planning to do with Bugworks in India, doing local innovation in India for the region where the patients are, where the disease burden is. So I think an interesting new let's say, business concept also, which hopefully is going to provide access to patients in the end. And from that, we moved over. GSK shared very interesting experiences on transfer of technology of their vaccine portfolio, also to Indian companies, Brazilian companies, and also how they actually, the challenges they are encountering in these projects. Rhonda, Assistant Director from PAHO, gave us a really interesting presentation on how they use pooled procurement in the region with the strategic fund. They are actually procuring for the whole region very first-line antibiotics like amikacin, benzathine, penicillin successfully, quality-assured products, in particular super important for, of course, small island states in the Caribbean who have small populations, otherwise would never actually be able to procure these products efficiently. And then we closed with Heba Dada, who gave us an outlook on what we can expect in Saudi Arabia, in Jeddah, in 31 days. And I think we're all looking forward to that high-level meeting and what we're going to learn from that.
Great. Thank you, Peter. So I think we have time to take 4 questions. We'll take 4 questions in succession, and then we'll have the panel answer. Please keep your questions brief. If you're trying to make a statement, hold it. We'll discuss that after the panel. Questions only. So why don't we start here in the front? I see 4 right here, actually. Yes.
Thanks. Elaine Fletcher, Health Policy Watch from Geneva. An excellent survey of the whole landscape from access to the development pipeline. But we know that animals are the main consumers of antibiotics, and all the problems you discussed about unregulated access in the marketplace, random use of antibiotics, how are there? I'm hearing more and more good conversations in the health sector. How can you inspire and promote and provoke the animal health sector to take this path that you're trying to take? Thank you.
Great. Let me take a second question. Oh, you have a, okay. Yes, go ahead. You have the microphone already. Yes.
So I am Dr. Aditya. I am from India. I am an adult vaccination specialist. So in ICU in our ICU we see that we don't have a proper mentorship, and they have the irradical use of the antibiotics. Irradical use of antibiotics, which is causing the more resistance. We have observed it, and we have created a cohort group, and we saw that after giving the mentorship to the people, we have changed the chains. But we have seen in the small chains, with you expert people are there, we want it to expand as a globally. So we want that the mentorship which is there should be decentralized, and it should reach the grassroots level. The education of the dangerous effects of the antibiotics. It should be understood by the public, it should be understood by the grassroots nurses, community health worker, they should understand. Because they also deal with antibiotics, and I have seen that they have used in the improper use of antibiotics, which we are having a holistic approach. Thank you, ma'am.
Thank you. So we take this question over here. Yeah.
Thank you. Emma Ross from Chatham House. You talked about the importance of political will. I just wondered if you could give us a sense of where you all think we are with political will and why you think we are where we are.
Okay. And one last question here, young lady in the front.
Hello, good afternoon. Please, this is a very wonderful session. My name is Tuntea. I'm a clinician from Accra, Ghana. So my question is that from where I come from, as the Honorable Minister said, we have a lot of drug peddlers who peddle these antibiotics and then increase the risk of resistance. So, and she mentioned political will. I just wanted to pose the question, how is political will, or what are the government agencies and these international forums doing for us to be able to combat this drug peddling of antibiotics? And secondly, what is the role of the physician in all of this? What can the physician do? Because the physician is in the middle of the policymakers and the patient, who's the end goal. So what is the physician's role in all of this to increase access and also response to AMR? Thank you very much.
Thanks. So 4 questions that could have been 4 whole panels, I feel like, so very good questions, but I'll hand it over to our panelists if, maybe just brief remarks from any of you or all of you on any of the 4 questions that were asked. Yes, please go ahead, Minister.
Thank you so much for the questions. When I said that political will is important, is because issues of AMR, the multi-sector, they're not just Minister of Health issues. No, it's you have heard about the animal part of it. I said, like in Malawi, because we have adopted the One Health, which is being advocated by World Health Organization, we have also involved the Ministry of Agriculture and then the Ministry of also Natural Resource. Because sometimes, and of course also the Ministry of Water and Sanitation. So when you have that political will, it's easier for different ministries to work together, different sectors to work together. Also, we also need the voice of the CSOs. When anything to do with the community, the citizens, we need the voice of the civil society groups. They have to understand issues of AMR so that they can go on the ground and assist our citizens, because it also involves behavior change. Why are we saying they should not get the antibiotics from the market? Why are we advocating for ABCD? For them to understand. So we also need to lobby the civil society groups, to add their voice to the issues of AMR. From us, from Malawi, we are very limited in terms of innovation. Like I said, all the antibiotics we have to get from outside. In terms of research, we depend on our partners as well. I've talked about we need strengthening of our laboratories in order for them to do maybe culturing to see which antibiotics are sensitive for this condition. All those things, we depend most of the times on our partners, international partners. So even that kind of collaboration, networking, supporting, you also need the political will from the highest office. So that is why I was saying, for us to win on this one, really, political will is very, very important. Thank you.
Anyone else would like to weigh in or offer comments? Any of these questions? Kevin?
Happy to. When antibiotics first came out, the animal and human use was through the same company, and they just used human antibiotics in animals. And over time, we decided, well, that's not a good idea. And then over time, companies set up separate divisions and did separate animal vaccines. And over time, they spun those off. And so I acknowledge the complete, human focus of this panel, and it reflects actually the structure of the way that the science and the funding from different agencies of the government and the way that the companies have been structured. So we have to do much better on the One Health side. On political will in a democracy doesn't come from an autocrat or clever conference speeches. It comes from the people mediated through civil society. And so the most encouraging thing I've seen in this last 2 years has been the way that the cancer community is waking up to the threat that bacteria, microbes pose to cancer therapy. And things like that deliver political will, not some magic cleverness at a conference like this.
Thank you, Kevin. So I believe we need to move to closing. And so I'd like to invite David Reddy, who's the Director General of IFPMA, to come up and give us a few closing remarks. And as he's coming up, a huge thank you to everybody on the panel for all of your reflections and thoughts. Over to you, David.
Thank you, everyone, and I'm delighted to be able to both join this event and close it. It's been a pleasure being here and hosting this together with CARB-X. As you know, the UN meeting finished only a few weeks ago, and we're moving towards the meeting in Saudi Arabia, which is the 4th AMR high-level event. Today we heard a lot of themes coming through about AMR, and I think one thing that's really important is we are getting a common understanding of where we need to go and what the challenges are. But what really struck me is, first of all, the stories of the personal impact, because this touches so many of us already, and it will touch so many of us in the future. And so it's something that needs to be addressed with absolute urgency. I think we understand many of the challenges, but also some of the ones that tend to be peripheral. It's not just about financing, it's also about people and competencies, both in LMICs, but also the lack of those needed to actually do the research that has become a critical issue. On-the-ground access is so vitally important. And hearing the comments regarding Malawi, and having a really firm understanding of community needs on the ground is essential, because without that, none of this will bear fruit and we won't make progress in the fight against AMR and in bringing antibiotics to those who need them. We do need to make progress on the business model. The UK, Japan have already made good moves towards pull incentives, and we heard today about the pilot that has been put in place by Canada. So there has been progress. There are a lot of remaining challenges, but I think the key message coming out of this is there is a real thirst to maintain momentum as we head into the meeting in Saudi Arabia. So wish you a good meeting in Saudi Arabia, and let's keep that momentum going. Thank you.